Good morning, everyone. I'm Robert Sumichrast, Dean of the Terry College of Business, and I want to welcome everyone to Terry Third Thursday in our facility here in Atlanta, the Terry Executive Education Center. This is a very special day for us for a number of reasons. We'll get to a chance to introduce our speaker in just a minute, but a couple things I wanted to make note of. One is that we are doing an experiment with today's Terry Third Thursday where we're going to be streaming this session to Athens. Some of you may know we've started remote alumni clubs. And we've got one in Charlotte now that's up and running well and one in New York. And we wanted to be able to have the technology to bring Terry Third Thursday to alumni groups like this in other cities. And so today will be a test, and then if things go well, we'll be able to not only have them see what's happening here, but also take questions and have a little bit of interaction with groups in other cities. Second reason that this is a big day for us is that U.S. News and World Report released their rankings of undergraduate business school programs this morning at 12:01 a.m. And I am very pleased to say that the Terry College moved up quite a bit. We ranked number 25 in the country. That's not among publics. That is 25 overall, and that's up from 30 last year. So, thanks very much. I think we've done a number of things with curriculum, with our faculty, with our students, and it's great to see that paying off. We have some sponsors that we couldn't put this on without, and I would really want to recognize them. We've got our friends at Bank of North Georgia here. They have agreed, in fact, to sponsor us, continue their sponsorship, and I certainly appreciate that. So let's give them a round of applause. We have two media sponsors as well that help us with Terry Third Thursday and with our programs, Public Broadcasting Atlanta and the Atlanta Business Chronicle, and I want to recognize them as well and thank them for their support. And just briefly, I want to mention some upcoming speakers. Next month, September 17th, we're going to have David Radcliffe. He is Chairman, President, and CEO of the Southern Company. I think everyone knows Southern Company is the largest energy company in the Southeast, and it's the leading producer of electricity in the whole country. So David will have an interesting talk for us in these times. In October, we'll have another Tim Chapman. He is co-founder and CEO of Stadium Money Management, which is in Watkinsville, Georgia. And his talk is an entrepreneur's spirit. Don't always listen to what they say. And in November, our final program for the calendar year, we will have Howard McClure, president of CVS Caremark Pharmacy Service. And he'll be talking about employee benefits and how you can maximize your contributions to those or what you get out of your contributions to those. As always, you can register for Terry Third Thursday through our website. Now, let me turn things over to Richard Kortz to introduce our speaker. I think many people in the room know Richard. He has been a longtime leader among alumni of the Terry College. He's a founding member of the Terry Dean's Advisory Council, longtime member of the Alumni Board, where he chaired the Terry Third Thursday Committee for quite some time. And I guess the Alumni Board thought his service was really valuable because they've now elected him chair of the entire board. So, Richard, can I ask you to introduce our speaker?
Thank you, Dean. It's great to be back here at Terry Third Thursday this morning, and it's my pleasure to introduce Tim Stack to us. Tim is President and CEO of Piedmont Healthcare. He's been in that position since 2001, but even before then, Tim was a leader in the healthcare industry. He previously served as President and CEO of the Borgus Health Alliance and Borgus Medical Center in Michigan. Before that, he was president and CEO of Southside Health Systems and senior VP and COO at Central Medical Center and Hospital, and both of those were in Pittsburgh. Under Tim's leadership, Piedmont has received a number of recognitions, most recently the Cardiac Care and Cardiac Surgery Best in Atlanta Piedmont has also been named one of the nation's wired hospitals for the 5 most consecutive years, as well as Atlanta's best places to work by the ABC in 2005 and 2007. Tim is currently the chairman of the Georgia Hospital Association Board and serves on the Georgia Chamber of Commerce. And Tim has also been the healthcare chairman of the United Way campaign for on 3 different occasions. But more importantly, I think I can't imagine a more timely guy to have at Terry Third Thursday, based on all the stuff that's going on out there in our economy and politically speaking. So with that, I'm going to introduce Tim Stack.
Good morning, everybody. Good morning. First, let me get one thing out of the way, that I'm a Michigan fan, all right? We were 3-9 last year, all right? I think the first losing season in 126 years. So it's, I took a lot of ribbing. I lost a lot of money. When you have Toledo beat you, all right, it's not a good season. Take that the year before, it was Appalachian State. All right? And needless to say that my chief operating officer's daughter went to Appalachian State, and he had that right on my door as I walked into my office. And he's not even a football fan. All right? 2, I need to share with you, James Shepard, who's here, is a good friend, but one of the things that I found out is that I guess I'm a cheap speaker, because everybody else, they charge you more for. And so James sends me a note and said, we have to give a discount to get people to come hear you. All right? So I'm not sure how good I am, really. I'm not sure I can talk to you about anything that after I talk to James, because he kind of puts me in my place right away. But I'm going to try to take you through what's happening with health care. I have been up to Washington 3 times, and over the last 7 weeks. I think it falls upon some deaf ears sometimes. I'm going to share with you what I think is good, what's bad, who the winners are, who the losers are, and if there's time for questions, I'd be glad to do that too. And I want to thank Richard. That I met Richard through his dad, who had served on the Piedmont board for years and years, and his mother, who is just a gracious lady, and she took me to my first ballet. All right, I'm not a ballet guy. I'm just not a ballet guy. I mean, these 2 foos, and they're going like this, and I really didn't understand. So Linda, Richard's mother, sat next to me, and I asked her when we're supposed to say score or time out, and she went right along with it. I mean, she was just a great lady. And then I looked over, and the seat next to her is Richard's dad, and I could see him snoring. So. So I thought, there's not much to this. You just learn how to go to there and just learn how to sleep too. But that was my first and only ballet, folks. I haven't gone back, and I don't plan on getting season tickets either. All right? Let me share with you now. I'll try to run all the buttons here. Whoops. All right. Let me talk about drivers for change, what's on the table, possible outcomes, and what's not on the table but should be. You all know, because the fact is a lot of you probably run businesses in here, you got spiraling cost. The costs are out of control. And I agree with that. I mean, I think we need to do some things to bring the cost. And one of the things you find is that I charge you $5,000, and usually I get back $1,000. All right? It's this allocation methodology. It's the way we've done accounting. It's the way healthcare and Medicare has been set up for years. And we've got to change that, because it just doesn't make sense to you. It doesn't make sense to me. And I've been in this field forever. Medical outcomes. Medical outcomes, the fact is, I happen to think the healthcare is good in the United States, but a lot of folks say we're not getting what we pay for. We're not having the outcomes as other countries across the United States, and there's a lot of folks that feel that way. Number of uninsured, you hear a lot of different numbers, about 47 million uninsured, too many for a prosperous country like ours, and we've got to get them insured some way. Think about insurance. You lose your job, you may not have insurance. You may be able to do COBRA, but then you're going to have to pay out of your pocket, and there's a good chance that it's going to be too expensive for you, and you won't be able to afford those payments. And then right now, it's a favorable political climate, and I think for a lot of reasons, the change, every so often, the change comes about, and this is one of those times. I mean, it's an opportunity. And I would share with you, I'm not one that would say we don't need to have change. I think we do. All right? I'm just not sure the magnitude, and I'll go over that in a moment. All right, bills in Congress. This is the chart of the bill in the House. I love the House. I mean, I've been up there talking to the folks, and this is the diagram of some of their bills and where they're at. So as you can see, it's a very simple, very easy to understand 1,000-page document, all right? So I'm sure they'll have no problems whatsoever as trying to understand that. You got one bill in the Senate to date, all right? And I had a chance to have dinner with Senator Isaacson, and he was gracious as could be. And but I think he's a lone voice, and I think that most of the Republicans that are serving on any of the committees, are far outvoted, far outdistanced. I hope it's more bipartisanship, but I don't think it will be. Just doesn't seem to be coming together that way. And as recently as yesterday, as you probably read, it looks like maybe it'll just be a go-alone, one-party type of bill. I don't think that's the best for the country, but it remains to be seen. As you know, and you probably understand this better than I, House, it's got to merge their three bills. The Senate, helping merge those bills. The Joint Conference Committee must reconcile the House and the Senate versions and bring that together. And both chambers have to approve the final bill, and then it goes to the President. Now, that was supposed to happen by August recess, all right? Pretty hard stuff. A lot of stuff, and I think that, a lot of kidding. When I was up there, I did ask everybody if they read it, and I would share with you none of them had. And that's a disappointment to me personally because, one of the things you think about, the stimulus bill and some others, and what we found out afterwards, that wasn't the best. I think that if we're going to have folks, we got to read these bills and figure out what's in them because there is some language that's a little scary and kind of hidden in different pages, and it just doesn't bode well. And the other thing is that, and I see a lot of young folks out there, and I'm very proud. We have, my wife and I have 3 kids, 29, 26, and a bonus baby who's 15. I tell everybody that the bonus baby because his name's Matthew, gift from God. But if it had been a girl, I would have called him Margarita. All right? Simple truth. All right? I blame my wife all the time. So I'm back, still going. I got parent-teacher conferences. At my age, I ought to be going to AARP. So we've got a lot of work to do, and there's a lot of things hidden in there that I just would ask you to make sure that you get a chance. Just follow the news, whatever you read. Just get the best information you possibly can. The common features are expand health care coverage, which is great. I think we need to do that because the fact is too many uninsured. Reform the insurance marketplace. That's got to happen too. You've got a lot of companies out there, and we got to figure out how to get more coverage to the folks, but make sure it's across state lines too, which it's not right now. You have Medicaid, and Medicaid needs to be, enlarged. It needs to cover more people. We need to look at the means test for it. We need to decide how we can get more people because a lot of those folks right now don't have coverage because they don't apply for it. And one of the problems you have is that it's there, it exists, but the folks just don't know how to do that. And you wouldn't realize sometimes that's the case, but it is. And we need to help the folks, really be able to do some things for themselves. One of the commercials I'll use is that Piedmont, we have what we call 60 plus. And if any of you don't have to be 60 to use it, folks, but if any of you have parents or anything else that use that program, we do it for the community. Nancy Morrison runs that, and there's a team down there. We'll help you with your insurance or whatever else because a lot of folks don't understand what it means to have, the different Medicare applications, the drugs, everything else you have out there, use that. We have a specialist. We have one woman. That's all she does. And she works with the folks. If you have a disabled person that, I have a sister-in-law that's slow. She's got about a 75 IQ, lives down here, and we have her in a apartment. And I asked 60 Plus to help her because you would think I'd know all that stuff, but I don't. And they helped her immensely because deciding on what are the plans that she should have to best serve her with her needs. And then subsidized low-income individuals and family. I mean, what we really have to look at, again, I think we're a great country, and we got to look at this and say, can we get coverage to some of these folks? They're talking about insurance exchanges, and I wish I could tell you I'm an expert on that, but I'm not. These are co-ops. I don't really understand them completely, but I think that it's a way to give options out there. It's a way to be able to serve. It's a not-for-profit way. And it requires employees to offer insurance or pay. And one of the things when you look at it is that should everybody have coverage? And, not all companies offer insurance to their employees. And that's one of the things. So that's going to be an added cost. But maybe it's a right. I don't know if it's a privilege or a right, and we're going to be debating that over the next couple of months, I'm sure. Or they're going to have to pay, and maybe as much as 8%, and a payroll tax of some type in order for that coverage to be held. The bundle payments to make medical costs more transparent. As I mentioned to you before, I may charge you $5,000, and I may get paid $1,000. We have different contracts with every different insurance company. All right? There's over 1,500 insurance companies out there. It is a nightmare. We got to make this transparent because when you get your bill, and I had recently a gentleman that I know, good friend of me, said, Tim, I was in your place, I had a half-hour PT, and you charged me $533. All right? I had to send him back. I said I got paid $100. But he's right. What he saw on his bill was $500. You look at that and say, that's just a huge charge for something for half an hour. We also have to look at medical education. Right now, we're not really growing our supply of physicians. And when you think about it, we have the same number of physicians that we had 20 years ago. And you're going to put another 47 million people in insurance. They're going to have coverage. And you're going to say they're going to get access. I have not a clue where you're going to get access, folks. All right? I have doctors that don't take Medicare now. All right? So the problem you have is that until we fix that, and part of my problem, this is all payment reform. This is not clinical reform. This is not education reform. We're going to have more doctors. Or we're going to have paraprofessionals. We started a school of PAs and physician assistants at Piedmont about 3 years ago. We have a class of 26 we graduate every year, and the reason being is they're going to have to help the physicians serve the patients. And that's the only way it's going to be able to work out, because until we figure out how to get more doctors out there, we're not going to have enough to serve us. I'm worried about myself, all right? I'm at an age now, I start looking down the road, I'm on the back nine of life, all right? I don't know if I'm on the 10th hole or the 18th hole, but I know I'm on the back nine, all right? And being on the back nine, you got to start figuring out, okay, how are you going to get care? Who's going to take care of me? I go to the doctor's dining room and I get an awful lot of, earaches coming out saying, they are just right now besides themselves, thinking about whether they want to stay in medicine or not. And those of you who have friends that are doctors, I think you probably have heard the same thing. They're looking at their salary going down. They're looking at all the things, and they just figure that, their place in society has dropped in their minds. And they're no longer really, as well thought of. I would share with you, they are not millionaires, folks. They are not folks out there that are, just gouging the system. They are folks like you and I trying to do their very best out there to really serve the public. And they're trying to do it as best they can. But they're feeling really put upon right now, and we're going to have to make sure that we figure out a way to make sure that we want folks to go into medicine. The average class right now is 54% women of a medical school class. The average time that they practice medicine is 8 years. all right, they have their second kid, they usually retire or they go back very much part-time. So that's another reality that's facing us right now that people don't really talk about, is that we have a shortage for another reason, because we are in a society now that really promotes, which I think is great, all diversity. But the simple fact is now, folks really, and I have to admit this, that I have every doctor that I lose, that I have to recruit or replace, it takes me 1.4 FTE because they don't work the same. Now, I'm not saying the young folks aren't hard workers, because they are, except they have a better balance in their life. They have a better balance with, how they treat their kids, and a better balance about being home, going to the PTA, coaching the soccer and the baseball team. So it's a different lifestyle. And the different generations, it's just the way it is. So there's a lot of factors out there, folks, on the medical supply side. Common features also restrict physician self-referral, and that really means that if you own something and a doctor, let's say, owns a piece of equipment, that it really restricts from sending to that piece of equipment because they're getting some payment for that. Cut Medicare and Medicaid payments to providers. I'm not really in favor of that, but I don't have much to say. Create a public insurance plan or set up nonprofit cooperatives. Probably the public insurance plan has the most angst out there. Now, the reason being is that, if I can kind of explain it this way, what you have is Medicare, which is about an 8% administrative cost to run Medicare. If you put a public plan in, let's guess it's going to run about 8% too. The problem is that you have the for-profit insurance programs that right now have to pay taxes, and they got to make a return for Wall Street. There is no way you can compete in that model, folks, no matter what you hear. All right? Just no way. And I just think it's ludicrous when we all talk about this. Now, the public plan may be good. There are some days I wake up on the right side of the pillow and say it's great. There are other days I look at, and because I don't make money off of Medicare. I don't make money off of Medicaid. Right now, the Piedmont healthcare system, we lose a nickel on every Medicare patient. Let's see, if I charged $1 for a Medicare patient, I'd lose 5 cents on every Medicare patient I treat. I make my money off the commercial payers. And that's the problem right now. And most hospitals are just like us. So that's what worries us. We're worried that if we just have a public plan and Medicare, we won't be able to survive. Same thing with physicians. So that's what's really a lot of the angst on this, and that's why there's a lot of pushback. And then pay for reforms. Pay is a big thing. This is $1 trillion program. I mean, this is not chump change. This is a lot of money that we're going to be spending. Let me go with my winners, losers, others. Possible winners, the uninsured. I mean, they have no coverage now, and they're going to get coverage. All right? We're going to pay for it. And primary care physicians. Primary care physicians make between $120,000 and $190,000 on an average. All right? And they probably have always been paid very poorly. And the simple fact is they'll probably get a little bit more money off of this. Paraprofessionals, as I talked about, we don't have enough doctors to go around. We're going to have the other professionals, nurse practitioners, PAs, nurses. Health information technology, there's a food frenzy out there right now because, as you know, with the EMRs and all the other programs, there are billions of dollars now for basically these records and others. So companies really are going to be winners out of that, because if it wasn't for that, each and every hospital will have to decide how to pay for it. Right now, Piedmont's way ahead of the curve. We have one of the most sophisticated systems in the United States. We're years ahead of most other folks on that, and we've already actually paid most of the money on our information systems. We'll get back right now $14 million if and when they decide to release the money. That will be our share that we've already paid towards our computers, and if it goes that way. And right now that money's not been released yet, and they're working through, and there's a committee But one of the things I found the other day is on the committee, there are only two healthcare professionals, one chief information officer from the Intermountain Healthcare System and one chief medical information officer that is from a system out west. And that's the only two healthcare folks on there. So the problem you have is we're trying to decide a system that's going to work for doctors and hospitals, and there's nobody really in there that has experience. So that does worry me. You know, as far as that comparative effectiveness, when you think about it, I mean, we've got to be able to measure and give you metrics out there. I want you to be able to go to our webpage. I want you to look and say, what's our infection rate? I want you to be able to do that, and I think you ought to be able to compare hospitals. And that's the way it ought to be done. I mean, when you really look out there, I mean, when you shop, you compare. And I have to be able to tell you what the price is. If you call me out and say, Tim, what's a CT scan run in your place? I say, I don't have a clue. You know, but I'm going to have to be able to do that. And that's the way it ought to be, because you wouldn't go in and buy a car. And if you said to the car salesman, what's that car run me? I don't know. You know, I don't have a clue. I mean, you're not going to buy the car there. So we've got to get more sophisticated on that side, and we will. And we're working on that with a couple of systems. Rural health care, one of the things I found is that because so many of the legislatures are from rural areas, that they're going to, I mean, they're making sure their voice is heard right now. So you're going to see rural health care probably, it'll probably be the best time for that ever since, probably the 60s, because they'll get a chance to put some things in there to help their constituents. And then medical education. I think they're looking at that and saying, okay, just as I mentioned to you, there's a shortage of physicians. We've got to work on that. I don't think there's enough in there. I don't think they really have an understanding yet. They really need to convene the academic medical centers to get them together and say, okay, what do you need? Where do you need to go with this? How do we get more students in there? How do we get folks that want to stay and practice medicine? Possible losers, health insurers, big way. The fact is they are getting hammered. And when I'm in Washington, nobody likes them. They just don't like them. And the fact is that I think whether it's a tax, I think that as you look at it now, they've already kind of given their pound of flesh. But when you think about the speakers and you think about the president, you think about even the news media, now they're talking about health insurance reform. Before it was health reform. Now it's health insurance reform. All right? They asked for the top 50 folks the other day. They want to know how much they made since 2002 up until 2008, what junkets they've gone on. They've asked for everything. Barney Frank, and I think there's a congressman from Michigan that have asked for it from his particular committee. So they're going to whack them, folks. You just need to understand is that they're setting them up for a fall there, and because they're making them out to be the bad guys. Specialty physicians, all my specialist friends that they think they're going to take money from them and give it to the primary care guys. All right? They're really worried on that too. Imaging, all these centers you see out there for the MRIs, go here, go there. They're going to pay a lot less for imaging to those organizations, including my own. And then physician-owned specialty hospitals, they won't be permitted under the current bills to build them. They won't be permitted to own them. And, they'll allow the ones that are in existence now, but there'll be some waivers that prevent them from building any more beds and doing some other things. These are too close to call. Basically, patients, are you going to do better or not? I don't know. I'm worried about that. I really am, because the fact is that I don't think you're going to have access like you think you are, because I think we're going to be overwhelmed in our ERs and our doctors' offices. Employers, you have paid since, the 60s, and you're going to continue to pay, and that's the problem. I mean, you are the deep pocket. So I don't think you really win on this one, but it's kind of, you're going to pay either way. Pharmaceuticals, there's good and bad for them. They've kind of paid their pound of flesh already, but maybe if more people are covered, that they'll be able to have more folks that they can take care of and get paid for. Hospitals, same thing with us. I mean, I'm a little worried out there that we'll have more patients that will have coverage, but I'll be paid less. All right? So you kind of look at it and say, geez. And if the private insurers go away, then, and I'm paid one flat rate, I'm worried about that also. Testing laboratories, paid less. Academic medicine, same thing. As most of the organizations. Nursing homes and medical attorneys, I think they're really too close to call because it can go either way for these folks. And the language is not final in any of the bills. Here's my points. And these are just from myself. And so, if you want to blame anybody, it's not coming from the AHA or the GHA or the, Piedmont. These are my perspectives on it. Tort reform. We've had tort reform here in Georgia, worked very well. I think it's helped a great deal. But tort reform is needed across the country. All right? And we need to look at that. There's really nothing in the bill about that. So there's really, doctors do order more tests because they're afraid of getting sued. And I would share with you, they do that. And I can't blame them because they don't want to be in a courtroom getting grilled out there saying, doctor, why didn't you order that CT scan? Well, it wasn't necessary. Well, sure it was necessary because so-and-so had this. Well, they don't want to go through that. So we got too much testing, and we need some tort reform. Barriers to hospitals and physicians. I can't really sit down with our doctors and go over and collaborate and really go out there and talk about things I need to talk to them about. And one of the things, because everything I do seems to be illegal, because over the last 20 years, we have put so many damn laws out there. All right? I don't have a clue. And they're worried about that, so I can't basically sit in the same room, which I want to. I want to sit down there and say, okay, how can we do a better job of doing this together? Why are we given this? Can we do standardized medicine? Some people call it cookbook medicine, but it's really kind of, you go down and say, what's the best way to take care of this patient? Most of the time, I either get grilled or I have in-house counsel, and it's amazing the things I can't do. All right? I cannot put in a contract with my doctors that if they want to help me save money, I can't put that down. All right? So you look at some of these things and say, please, let's work on that. More focus on preventive care. I don't get paid for keeping you well. I get paid when you're sick. And that's goofy as can be. All right? Let's figure out how to do it on the front end. Let's figure out that, I smoke cigars, drink wine. The fact is, I ought to pay more. All right? I should pay more, and I believe that. And so we've got to look at these different things and say, hey, let's figure out how to do this. Now, if somebody runs and they weigh half the weight that I do, same size or whatever else, and in great shape, they probably should pay less. That's okay. Lifestyle choices, let's face it, what we've got is a real problem. We've got obesity in this country, unlike anywhere else. And it's probably our fast foods, it's our food processing. It's a whole host of things out there that, other countries don't have. So we're going to have to look at that and say, what do we do different? What do we want to do different? And explicit end-of-life policies. I think, a lot of hay has been made on this by both parties, all right? But here's what it is, that we spend more that last month than we really do for anything else. Let's figure out right now, we've got some great programs. You've got some places you can go, hospice, other things. I had both my mother-in-law and my mother both died here in Atlanta. One is an inpatient and one is an outpatient with the Atlanta hospice. They did a fantastic job. My mother wanted to die at home. And the fact is, they came in, they were just the greatest nurses. And my mother-in-law, she went into Atlanta hospice and the room and everything else, and it was fantastic. 1/3 the cost. All right? They were both going to die. But the fact is, it didn't happen in a hospital room. It didn't happen that way. And it was just a great way. So kind of end of life, figure out. Public opinion. I think the support for reform is positive but declining. I think the numbers and the polls you look at there's a lot of confusion, folks. More and more each day. You got competing priorities, continuing economic crisis. I think what happens, we've spent a lot of money. There's no way this program is going to get paid for by savings. I want you to know, I've been a CEO since I was 29 years old, running healthcare, and there's just no way. It just ain't going to happen. You're going to pay. And so the fact is, we talk about savings, even Medicare. Medicare's going broke. All right? So if you think the savings is coming from there, no way. The problem is right now this program may be too expensive. And, the pharmaceutical companies, generic drugs, a lot has been said with the generic drugs. I think it works pretty well. But the other thing I laugh about, when you look back over the last couple of years, I get up early. I try to put on the news downstairs and get a cup of coffee. And when I look at it, every single drug out there you can imagine. All right? And they're all advertised. And they're all marketing directly to you. All right? Or to me. And the fact is, and they want you to go in the doctor's office and say, I want so-and-so. All right? Because they don't want you to buy the generic. They want that specific drug because it's going to cost you more money. Here's my forecast. It is going to be cloudy and stormy. All right? I think what you have is that three things can happen. One is to shake up the system, and that's complete change. I don't think that's going to happen, all right? I think that would be very difficult to just ramrod through, and I hope they wouldn't do it. I hope there's incremental change, though, and I hope that there's language and others that, that we can change some of these things to make it better for you and to make it better for the folks less fortunate than us. And we need to change, folks. The system is broken, all right? It's just the magnitude that, it's almost like you threw out the baby with the bathwater. Well, if we go whole hog, that's what we're going to do. And I think we may actually destroy a system, and it's going to take some time to come back. Or do nothing. And that'd be the worst thing, folks. You only get a couple chances like this in your lifetime to really move forward and to have a wonderful opportunity to change a system, to really vet out what is wrong with it, to fix something. So I think we really need to take the opportunity. As I said, year end, I think by December that we will have something in front of the president, if not before. And I hope it's the middle ground because I think there's a lot of things. In fact, I shared with my team the other day, I belong to a group called the Academy of some healthcare executives, and there's about 25 healthcare systems from across the country. And we developed a position paper, and one of our constituents of those 25 systems, they are in Montana. And they actually are in Max Baucus's district, and not district, in the state. And we're going to present the position paper to him on Monday. And I'm having my team scan it today and some of our group because it talks about different reform that needs to happen and to make it better for the patient. What needs to happen with the doctor and make it better for the doctor and all those other issues. And it's about 4 or 5 pages. And we're hoping that Max looks at it and that he gives us some credit, takes it back into the into his committee and discusses it with that group because they're basic things. They're not wild things. They're not wish list. They're basic things that perhaps can help the field. We're not taking it through the AHA. We're not taking it through the GHA. The fact is, it's just, we represent 40 different states. We represent half the beds in the United States. And what we're doing is just taking it as a group of interested folks trying to speak for our constituents out there and see whether or not that maybe somebody or a committee like this will listen. I think it'll get some traction. Already that we've talked to Senator Baucus, and he likes that because he recognizes, what he's seen so far is a huge bill and all the fighting and everything else. And these are issues I think everybody can talk about, and they can talk about with their constituents without the fists coming up. And healthcare reform, chronic condition. So it's at that stage. So I'd probably end there and just ask you if you have any questions. And I don't know if my time.
Yeah, we've got time, but let me ask that If you've got a question of Tim, we've got some microphones around the room. We are recording this session as well as streaming it to Athens. So please, raise your hand, get a microphone, and that way everyone will be able to hear you in the room as well as get you on the recording. So,
thank you.
Take it away.
Thank you very much.
Any idea why tort reform is not on the board? Is it because they're all attorneys?
Yes. Yes. I think tort reform, and again, I'm not picking on the attorneys because some of the attorneys are my best friends, but I believe that that's why. I mean, I simply think that, any magnitude of reform is going to have to look at the payment system, all right, and the money there, and that's really not on the table right now. Yes, sir.
That was part of my question. Is, can you be specific on what tort reform savings could bring? And if you can't answer that, it's maybe not the right forum for that. Can you talk about your preparedness for the swine flu pandemic and what that could do to the healthcare system?
Yeah, that's a great question. I can't speak to what tort reform, the money. We've not run the actual numbers on that, so I don't know. I think that on the swine flu, we're lucky. We got the CDC here, all right? And because of that, all the organizations are very well prepared. I think that, here in Atlanta and the state of Georgia, a lot of work has gone in both by the medical societies and the hospitals. We run programs continually just to be prepared for it, for the isolation, what we need to do, the shutting down of the wings, the isolation, you name it, having the right antidotes, having the right prescriptions, having the right medicine. Yeah, it's taken a lot of work, but I think well prepared society is, and it's mainly because we've had a good year really to get geared up for it. So I think you'll be pleased, no matter where you go for your hospital, that they should be really well positioned for that. Yes, ma'am.
I think you probably are familiar with the medical home concept. Have you? I have not seen anything in the state of Georgia about that, but I've seen some of the results in the Northeast and the Midwest. Do you think that concept might have any part of this healthcare reform?
I think it can. I think the medical home concept, when you look at it, that's one of the great ideas. And that's one of those things that needs to be followed through on. And, I kind of look at it back that, I grew up long enough that doctors still made house calls. I remember when our pediatrician came to our house, either for me or my sisters. And so the simple fact is I remember those days, and I think some of these concepts kind of take you back a little bit because they're going to really kind of work with you, try to help you, and, a doctor really that you're going to trust and know. And you probably know this, and this is not quite to her question, but one of the problems you have now is that your doctor that you see maybe on a regular basis for your physicals really doesn't follow you in the hospital anymore. You have doctors called hospitalists because the doctor really doesn't make any money when he's in the hospital, the internist, your family doctor. And part of the problem now, you have these hospitalists that see you maybe once in your lifetime. They don't know you, and that's the problem with this right now. The concept she was talking about maybe may take us back a little bit so the doctor follows you. And they have more of a reason because there's a payment system tied in there that they can follow you in the hospital without losing money because they're not in their office seeing patients. So those are the things we need to fix, and we've just gotten away from them. And I don't know why. Well, I do know why. It was money, all right? But we need to go back and figure out how we can do that better. Yes?
Yeah, I was curious to hear your reaction to the New Yorker article about the extraordinary differences in per capita costs between McAllen, Texas, and El Paso, Texas.
Yeah, I think if you have a lot of entrepreneurs, you have a lot of enterprises that are privately held, you're going to pay a lot of money. And, the problem is I thought it was a great article. It is reading number one on the hit parade up in Washington, D.C. They used it everywhere I went, talking about that. And it's really a question of ownership, and that's why they want to drive the for-profit capabilities out of the with the physicians, because there's a case, with the heart hospital there and some others, that there's no better outcomes, yet the cost, are double, triple the of other places in the country. Same thing is true, though. I would share with you right now that the cost in New York City compared to Atlanta. All right, New York City, their costs are double. I tried to recruit. I was recruiting a open heart surgeon. You'll get a kick out of this. Recruiting an open heart surgeon, and here's the deal. He makes $2 million. He's got a townhouse. He has a chauffeur. He has a butler. All right, and he has a country club membership. And there's no way I can compete. So we wonder why the costs are more. Sometimes, these salaries are out of whack. I've simply found out after trying to go after a couple real superstars in New York City, I can't compete. I can't pay anywhere near that. And the fact is that's what the going rate was in New York City. Now, I know the costs are more and expenses and everything else, but he asked me for the same thing. In fact, he asked me for a membership in at Augusta Country Club, I'm looking around, Yeah, like I can do that, So, it was a little ridiculous, but but those are the things. Yes, sir.
I think I understood you to say that you thought that insurance companies had paid their pound of flesh, but as a layperson over the last 5-7 years, I've seen something that seems to be a disturbing trend. I have friends who were retina surgeons, and they gave up their practices because they were being told that their patients, after they replaced their retina, had to leave the hospital after 1 day instead of the 3 days the retina surgeon said. I'm seeing a really disturbing trend lately in which the insurance companies are taking prescriptions that doctors send, and they're saying instead of 12 of these a month, we're going to let you have 4. So how's that working?
Well, I really think the question is that you've got a middleman between a doctor and the patient. And, I think the problem there is that, I've always believed, and this is just my belief, and again, I just speak for myself, I think insurance companies should be not-for-profit. I think we have gotten ourselves in a horrible mess over the years by taking these companies private. And most of the time, because what we do, we put them in the reality of every other business that they have to make a profit. They have to maybe make a 20% return. They have to be able to please Wall Street. And when I really think about it is that if they were not-for-profit, like Blue Cross of Georgia was at one time, all right? The difference there, what you would find is that you'd have a much lower administrative cost. You wouldn't have that big profit motive. You wouldn't have quite that, that fighting that would occur. And the beauty of that is that you'd still have the same number of employees. People would still have jobs. You're not getting away with the industry. They serve a necessary function. But what you're not having is for them to have this profit margin that they got to exist on. And in order to please Wall Street, in order for their stock to stay at a certain price. So I would just take that out of the equation. I used that with Senator Isaacs, and he loved the idea. I would share with you. I had breakfast with Newt Gingrich and Tom Daschle back about a month ago, and they didn't like the idea. All right? So, I would share with you. It's fallen, on some good ears sometimes, but on deaf ears some other times. I just think it's not a business. It puts an inherent conflict in place when they're for-profit. Now, I know the insurance companies, and some of you here and work for the insurance companies probably disagree with me, but I would share with you, I think it was much easier negotiating back when they were not-for-profit. If you remember well, we moved away. Piedmont walked away from a contract, and the reason I walked away is we have a huge clinic, 600 doctors, and they wanted to pay our doctors 3-year contract, 0% the third year. I said, you got to be nuts. I said, cost of living, whatever else. I was asking for 4%, 3.5% or 4%. So it wasn't ridiculous. They said 0. So that's why we walked away, folks. All right? And so when you look at it, you just want to sit out there and decide that you've got to be fair. And it was a lot easier, I think, when it was the not-for-profit side. It was a little easier. Though I would share with you, we just had negotiations with the payers, and it went extremely well this past summer, and there was no fighting. I mean, the fact is they were settled before time. They were closed before the clock struck 12. I mean, we had good opportunity. Yes, sir.
Tim, the health insurance market is different from other insurance markets in that it does provide for employer-based insurance. That's not the way it is for your home insurance, for your auto insurance. First of all, without going into 30-minute history, but maybe you can explain briefly why is that the case? Why is that market unique like that? Number one. Number two, do you think that, to your point about increase in visibility between consumers and providers and eliminating the middleman, or is that one of the things that we can do to actually reduce cost in the system and make the system more competitive?
Good question. That when you think about the problem with health insurance is, he mentioned that when you go out and buy your car insurance, you go right to your broker and, kind of you're doing it independently. Most of the time what happens is that on your health insurance is covered by your employer because that's one of the benefits they could give that really wasn't taxed. And that's why it came about. And so, that was started years ago. It's been in place. And most of us in this room, that's what we've grown up with. All right? So that's the way it is. Now they're looking at that and saying, should that be taxed? Should we be looking at it a different way? I really don't know. I have some opinions on that, but I think from a standpoint, the system is what the system is. I mean, I would rather see you have a little bit of decision-making on that. I think we have taken that out of your hands. I think you need to have that decision-making. I think if you decided that you need this or that, you're the ones that ought to make that decision, all right? So I think that's a better way to go because, that's another crazy thing about what you're hearing out there, saying you're going to have your same doctor. No. All right? It's whether we choose the employer that we're going to be in that plan if those doctors are in that plan. So that is downright wrong. All right? You're not going to have your doctor. You may have your doctor. All right? Depending on what plans they're in and who they're covered with. And that's the way it works. I mean, I will share with you right now. So all those activities and how everybody's talking about it, there are some things that are just plain false out there. And I'm ashamed to hear those because, I would rather have us be honest with you and say, okay, here's what it is. There's some great things in that bill too, though. But there are some things that, no. From your doctor's standpoint, you may or may not have your doctor, depending on what happens with this reform and whether they're in it or not. The insurance plan. And that'll be a decision reached by the doctors, the hospitals, and other folks. Yes, ma'am.
This is a question from the audience in Athens. Any guess on the magnitude of the cost and what an individual might expect in the way of percentage increase in payments or taxes?
What we're talking about right now is probably $1 trillion, the magnitude plus. I think it's going to be a lot more than that. Everybody's trying to get the bill under $1 trillion to say it's $900 billion. I never knew what a billion or a trillion was until the stimulus package. I really didn't. Now we talk about these numbers like they're pennies, don't we? It's crazy now because $1 trillion, it'll be probably the additional cost out there. As far as, what it'll mean to us, I think that, the folks making over $250,000, they're going to get wrapped. You're going to pay a lot more in taxes. I think, I even think the middle class is going to get wrapped. All right? I just think that there's just no way you can cover all this stuff without extremely taxing. It's tough times right now. We've got a lot uninsured. We've got a lot of problems out there right now with our own economy. I think it is starting to perk back up. I'm optimistic right now. So I think that, from a standpoint for our friends in Athens, they're going to pay more. We're going to pay more in Atlanta. We're going to pay more in Georgia. Right now, what I'm worried about is that I'm hearing talk that there may be a hospital tax coming up this session because Medicaid is losing money. They don't have enough money to pay for Medicaid in the state. And even though there were money sent to the state for Medicaid, because there's no constitutional amendment on that, they can put the money into different pockets. And they can put the money into different categories and silos out there to help pay for other things. And that's what's happening right now. So there's just a small amount actually going into Medicaid, and the rest is going to cover other shortfalls. So that's another worry we have. I said, you know, if I wasn't so old, I wouldn't sleep so well. You know? Any other questions that you have been at? Yes, sir.
Since you've mentioned them, I'll go and ask a question about them. As you know, Blue Cross, likes to buy a company a month, and perhaps we talked about nonprofit versus profitable companies, and would it be easier for you, a hospital, if you didn't have a Blue Cross situation who buys up all these companies? Because on one side, you're working with less companies, but on the flip side, you've got Blue Cross, who is so bloated that you've got the financial restrictions, and they've got the power. They can come to the table and stomp their foot and do what have you. From a hospital perspective, where is the middle ground for you, or where would you like to see the comfort level be as far as a hospital administration, as far as working with companies?
To be fair, that, again, I think, and I've always said this to the doctors at Associate and the hospitals, I always say we're on the side of the angels. And the reason being is that if you, God forbid, but if you walk out of this room and you trip, and I asked you, are you going to the local ER or your doctor's office, or are you going to the front steps of United or Blue Cross to get treated? You know where you're going. All right? So the simple fact is that I kind of look at it from a standpoint that, and we debate this issue, as you can well imagine, a lot of folks. But I believe we're there to take care of you, whether you pay or not. All right? I hope you pay. But whether you pay or not, we'll take care of you. And just like Grady, we need Grady. One of my heroes is Bernie Marcus, because Bernie Marcus gave $20 million to Grady. And I had coffee with him the other day. And I'm sitting down, and Bernie's really a unique guy, all right? Really speaks his mind, but he said, and I congratulated him about doing that. He said, I did it for you, Tim. I said, get out of here, Bernie. I said, give me the $20 million then. What am I, chopped liver over here, Bernie? So, no, he said, I gave it to Grady for hospitals like you and Northside and others, so you wouldn't have to, do some of the things that Grady does. So, he's a great guy. When you look at that, and he really has a command of understanding what's really happening out there. So, I'm not trying to be evasive about your question, but I think probably that I always thought the insurance companies ought to be not-for-profit. I think it'd be a lot easier for them out there. I think that, the buying is because, again, Wall Street, some of the excitement they need to have. I ran a publicly traded company one time in my life, and I understand that. I understand how the, quarter to quarter, you got to be able to talk, and you got to do things and everything else. That's what the analysts want. It's a tough business out there, especially in the current days. Yes, sir.
Okay, I think this will have to be our last question.
Okay, thanks.
Please be patient. English is my second language. And the question I have...
It's mine, too.
The question I have is this. We talk about 47 million uninsured. We also talk about 12 million illegal immigrants. So that boils down to maybe 33 million people. Now, of the 33 million people, how many of them do not want to get the coverage that could afford that? And also, could we push the immigration reform so those 12 million illegal aliens could come up to the light and be insured somewhere, somehow?
That's a great question, and I wish I had an answer for you. There's about 10 million that don't have coverage that should. They just don't do it, all right? As far as the, an answer to the rest of your question, I don't have one. I wish I could tell you that I'm just not that smart to figure that one out, and I know they're looking at that. And I think that from a standpoint, a part of my problem, I guess, in looking at it is I don't know, just a personal question, I guess, on the 12 million illegal citizen, folks here in the country, I don't know if they should have coverage or not. I mean, I think from a standpoint, our ERs take care of them, all right? And there are a lot of clinics and maybe other things we should do even better. I mean, we have the clinic up in Jasper. We have one down by Grady, and that our doctor staff and that we pay the supplies and everything else. And, I mean, because there are people a lot less fortunate than us. I mean, we're blessed folks in this room. I hope you all have your jobs and your health, but there's a lot of folks that don't have any of that, and they just don't have any way to, get around it. And you just have to, you have to look at it and say, okay, can we do it a cheaper way, a better way? Right now we're studying some things. Some of our folks looked at the community benefit. Piedmont gave away $88 million last year. Not gave away, we spent on community benefits and doing things out in the community. And, that's not chump change. I mean, it really isn't. I mean, it's a lot of money out there we're spending to take care of the community. And you would think that we're blessed because we're in Buckhead, I mean, our flagship. Well, we are, but we also have a place up in LJ, and it's got a huge Hispanic population up there. We've got down in Fayette, Noonan. And even then, even in our ER, it's changing right now as we speak because, less fortunate folks are coming in. And we'll take care of them. I mean, we've got to take care of them. That's our duty, that's our responsibility, and it's a privilege for those of us that practice medicine or take care of patients. I mean, that's what it's all about, folks, that we do that. So I think what you're going to see, we've got to look at that reform, and there are earmarks in there looking at the clinics and different ways we can do it. So I thank you for your question. Folks, you've been a wonderful audience. I thank you. Thank you very much.
Thank you.
Oh.
Yeah, Tim, on behalf of the Terry College Alumni Board, I want to present you with this sculpture from a local artist, Paul Benzunas.
Oh, thank you very much. It says, to a Michigan fan, 3-9.
All right,
thank you.
And for those of you in the audience, remember, just say Terry Third Thursday on your way out. That'll get you out of the parking deck. Hope to see you next month.